When we're talking about open innovation, most of the time we're talking about private corporations. Open innovation might be a very useful innovation tool also in the public sector. That's the reason why, as part of our Corporate Startup Stars Awards that we run annually, we introduced 2 years ago an award specifically focused on the public sector to recognize the organization, public organization, government organization that were able to innovate through open innovation and through startup collaboration. And today I have the pleasure to have with me Martin Curley. Martin is in charge of digital transformation and open innovation at HSE. HSE is the public health and social care organization in Ireland. And Martin, welcome to the show.
Thank you, Alberto. It's a pleasure and a privilege.
So, Martin, as mentioned, HSE has been recognized last year as the award winner for this special category that we introduced a couple of years ago. That is the Public Sector Open Innovation Award. So, first of all, congratulations are in order for the job that you guys have done. But again, the goal of this conversation today is to try to understand what you guys have done in order to open the public administration to the world of startups. I remember in our prior conversation, you mentioning to me that before 2019, HSE was impenetrable to startups. And then something has changed because based on what we have seen, you guys were able to initiate and then effectively execute some valuable collaborations. And so, first of all, I think we'll ask you to just introduce HSE and explain what is the context and explain what brought HSE to open innovation and startup collaboration.
Great, Alberto. Well, thank you. Well, the HSE, or the Health Service Executive, is the primary service delivery organization for health and social care in Ireland. We have about 130,000 employees between direct and indirect employees, and we're kind of the equivalent of the NHS in the UK. As you mentioned, actually, in the past, the HSE was impenetrable to startups. And in fact, most public servants aren't incentivized to innovate. And in fact, a healthcare system is actually designed to minimize variation because that's how you maximize quality and patient outcomes. So in 2019, a new organization was founded, and I had the privilege of starting it up and leading it with digital transformation and open innovation. And we started at with a recognition that healthcare in general was about a decade behind in other industries such as digitalizing, or industries such as the music industry or retail or manufacturing or financial services have all digitalized. But the paradox is that healthcare is probably the most information intensive industry that exists, but it was the least digitalized. So we recognized that there was a real opportunity, and we also recognized that Ireland was particularly a laggard amongst OECD countries in terms of the adoption of digital. So we're kind of at a unique point in time where we have multiple disruptive technologies all showing up at the same time, from cloud to machine learning, artificial intelligence, blockchain, mobile social, etc. So there's a perfect storm of technologies, and you can either ignore those or you can really take advantage of them. And digitalization is really democratizing innovation, and it's enabling a whole new world of digital based SMEs to provide new solutions. So we thought about how could we engage these SMEs and co-design new solutions with them. So we designed a new innovation pipeline which simply had 4 phases. We started with an exploration phase, then we went to a proof of concept or pilot. If that was successful, we went to a demonstrator where we would prove the business case and then we would go to broad adoption. So we created an instrument called a living lab, and a living lab is a key construct of a paradigm that we call Open Innovation 2.0, where we are absolutely sort of innovating in the field, in an acute hospital setting, in a patient's home, in a community setting. So we put out a call on our website, innovations, and a little after we started the organization, COVID came around and there was a desperate need for virtual healthcare solutions. So we opened up a call for 2 SMEs and large companies, but we got a huge response from SMEs, and we quickly started to co-design digital solutions. So one of my favorite examples is with a small SME called PatientMPower based in Dublin. And, in the space of 5 weeks, we went from a prototype to broad deployment of a solution for remote monitoring of COVID-19 patients. So we actually demonstrated the prototype in public 2 days after we actually conceived the prototype. We had a working product in a week and a half, and within 5 weeks, we were in 30 different acute locations across the country. The interesting thing is that normally the lead time to develop such a solution and deploy it and adapt it would probably be anything between 2 and 2.5 years. And we were able to dramatically decrease the time to market for these solutions. So this Open Innovation 2.0 approach, where we were co-designing with SMEs, proved very fruitful. And in a number of cases, we were able to move very quickly through the innovation pipeline from an idea or concept to actually a deployed solution.
But Martin, again, is obviously is amazing to hear about the results you were able to get. The real question, again, I'm putting myself in the shoes of your peers across the globe that are are sitting in the public administration. They probably have the same motivation that you have to innovate, the innovation pace, but they have to fronting and facing the red tape, the bureaucracy, the complication, the scrutiny that also is very legit, that being part of a public government, public administration brings with. And most of the time, beyond all of the red tape, there is also the mindset that, as you mentioned, is a mindset where change is not part of the plan. And what this has always been done in a certain way is the typical mantra. So why are we supposed to change? We've always done this way. It's impossible to change. So I suspect that you have faced many of these objections. And can you share some of some anecdotes and some tips in the way you were able to come around this, to pass these barriers, to break these barriers, to change this mentality? What did you do? What did you do?
Yeah, no, that's a very insightful question. And Alberto, and you've identified actually some of the key challenges. What was most important for us was to identify a clinical champion, a senior consultant, or, it could have been an add-on or whatever, that actually was interested in change and was willing to partner. So that kind of was the number one requirement, that there was a consultant who saw that a clinical practice could be changed through digital technology, and that was a hugely important enabler. But you're absolutely correct. Public sector organizations aren't designed for innovation; they're designed for the status quo. And there are benefits, of course, you need to have in terms of you need to have a very smooth operational machine. So you want to minimize variation. But our motto is dream, dare, and do. So we try to imagine what this better future could be. We actually dare to do it, and we get some clinicians who are willing to come on the journey, and then we just do it. So you've probably heard the expression, seek forgiveness rather than look for permission. So what we very much have done, like the Nike motto, just do it. Despite objections, we have just done it, and a couple of times we've had to put our fist through a plate glass window to get our solution implemented. But once people start to see the solution and they start to see the benefits, they actually come on board. So an example, we worked with a company called PMD Solutions, who have a very novel automated respiration rate measurement tool. And this is the dirty little secret of the healthcare industry, that we know that the respiration rates that are calculated by nurses often are inaccurate, because it's actually very difficult to measure, and you get respiration rate variations from minute to minute. So we were able to find a really good clinician, Professor Richard Costello in Beaumont Hospital, and we approached him with the SME, with this technology. He said, sure, I'd be willing to try this. So we actually put it into our Beaumont Hospital in Dublin, and we started to trial it, and it started to produce very good results. And then we enlisted the support of the National Clinical Lead for Respiratory, Dr. Des Murphy in Cork, and he said, well, I'll try it in my hospital. And he tried it, and actually it was very effective. So between those two clinical supporters, we were able to convince their peers and the corporate HSE organization that this is a technology that would be worth investing in and deploying. And right now, we're just wrapping up the deployment of this technology in about 25 acute hospitals across Ireland. And so the critical thing was, we had a consultant or a couple of consultants that were interested in improving the situation, and there was a real problem to solve. And the problem was that we didn't have reliable respiration rates being. And what we were able to find, particularly with COVID, that with this RespiroSense technology, that we were able to get 12 hours advance notice if a patient was going to have a hypoxic event or going to significantly deteriorate. So it turned out to be a really effective solution. And now Ireland will be one of the first countries in the world where automated respiration rate measurement is the standard of care, is the normal standard of care. Normally that only happens in ICU or in resuscitation.
That's great. And I think out of this example that you just mentioned, I think one point was very relevant, again, also for the audience, is the best way to innovate in organizations that are used to the status quo, as you mentioned, is to make things happen. And when people see the results, they typically jump on board the bandwagon. And probably, again, it's leading by example, leading by facts. The problem, the objection to such an approach is, if you do like this and nothing happens, everybody's pointing the finger to you saying, told you, it was impossible. And actually, they are not cheering for you, they are cheering against you typically, because you are the one that are breaking the rules. So you're taking a big risk. And the next immediate question is, what is your motivation to do something like this? Because again, if you do something such, let's say, non-conservative, typically people are not cheering for you. Typically people are cheering against you. If you do something wrong, they will point the finger, and actually you might have consequences. If something happens, you might be an hero, but again, it's a very, very narrow path. So again, and everything starts with motivation. Few individuals that really wants to change the status quo. And again, motivation is not a strategy, because again, it's based on individual characters. So what could be the secret sauce to make this more broader? Because again, we cannot rely on motivation. We cannot just rely on people like you that want to change the status quo. We need to make this the new way of doing.
Yeah, that's a great question, and it comes to culture, and culture is a huge issue in terms of, actually, culture is probably the most important thing, other than having a problem to solve. But one of your fellow countrymen, Nicholas Machiavelli, he talked about there's nothing more dangerous, more perilous to undertake than to bring about a new order of things. So, at best you get orders, and you get a lot of people that pose you. So what we've tried to do is put a process and a structure in place using our living labs, where we're able to legitimately experiment. And this kind of structure, and the more times we do it, people start to get the idea. Okay, it's okay to, and you know that sort of maxim, fail fast, learn fast. That it is okay to fail. But what we found is actually, when we set up the living labs, actually most of the technologies that we're deploying are actually successful. And when we have an overall strategy called stay left, shift left, and this talks to your motivation question. You know, the motivation is really to make a difference and transform our healthcare system. So stay left refers to, if you're a well person, we want to still keep you well, or if you happen to have a chronic condition that you could be managed best of all from home. And shift left is about moving patients or citizens as quickly as possible from an acute to a community to a home setting. And we're all the time looking for digital interventions that will help with this overall strategy. And we look for 4 kinds of benefits. We're looking for an improvement in the quality of care, in a reduction in cost, an improvement in quality of life, and an improvement in the clinician experience. So we're looking at all of the stakeholders, and if we can create a better future for all of those stakeholders, it significantly reduces the barrier to adoption. So as we engage with clinical staff, we're trying to prove out, well, what might be the potential benefits in the proof of concept, and then, you know, work out actually the business value, and we're hopefully able to develop a business case. But it also requires innovation from the SME. So one of the most innovative SMEs that we worked with was a company called Salasso, and they develop solutions for virtual rehabilitation. And we partnered with them, but they were very smart. So at the start of the COVID pandemic, there was a real need for virtual rehabilitation. So they started to actually give free licenses to physiotherapists across the country to use their software, and there was a critical need, so there was really broad adoption, and soon, you know, they were being used in 20 centres across the country. And then we mobilized to create a call for, we issued a tender and a call for responses, and they were really well positioned and were very successful in winning the tender. So sometimes it also takes novel approaches from the SME to get adopted, and I think that's a really good best practice for other SMEs trying to get adopted, to actually give a free license, let clinicians use it, and pretty much it becomes embedded in the clinical flow and can't be done without. But I think, yeah, innovation is inherently risky, and I think, Alberto, the data from Dublin Group would say that just 6% of innovations actually turn out to be successful. We try and actually manage a portfolio of disruptive technologies, and we score those technologies, and we try and pick the technologies that will have the most benefit and actually have the highest chance of scaling. So an organization like the HSE can do everything it wants, but it can do anything it wants, it just can't do everything. So picking those 5, 6, 7, or 8 solutions that we think have the best chance of success and the best chance of, you know, value creation and transformation is what we go after.
You mentioned the word tender. That always is raise the question. Then, okay, is not exactly the way to onboard effectively partners, because again, it passes through process of selection that sometimes, also because also you're part of the public organization, need to follow rules, procedures. Most of the time it's lengthy, complicated, and most of the time it doesn't even allow to pick up the best solution, because again, there are limitations. And so I believe that one of the main obstacles are also the equivalent of the procurement system, again, because you need to bring on board external organization, there are rules to follow, there are processes to follow. That might take time and might probably discourage the best providers to join. Similarly, I suspect that being a public organization and needing to do such a big change effort, you might probably need also external resources like consultants that might help you in the process, but also the budget for hiring these people is quite limited and the process of bringing them on board is limited. Again, there are a lot of obstacles that I'm pretty sure you navigated through. Can you give us some highlights of this and the way you try to minimize, if not to solve?
Yeah, that's a really informed question, Alberto. You clearly understand the difficulty of innovating in a public procurement organization. So we have an innovation pipeline, as I mentioned, and we have a governance over that, a digital solutions review board, which has representatives from across the business, as well as the IT and digital people. So we make the barrier very low. So in the exploration, we're just, talking about the technology and looking at it. But the first entry step is our proof of concept, our pilot. And typically we're able to award below 25K to the SME to get started. So typically what we will find will be to the Digital Solutions Review Board. And we are able to award, we need to get 3 quotes from competing vendors, although what we found sometimes actually the SMEs that we've been working with actually have unique technologies. There's nobody else in the market. So we make the barrier low and the bureaucracy low around the first step. And typically, the HSE will fund some of the investment. The SME will fund some of their investment, and potentially we have a university or a patient group that are co-investing. So we're able to do, get started on the innovation run quickly with a low barrier for entry without the need for a big tender. We have a very simple call that a company responds to. And then we have the opportunity to use procurement instruments like pre-commercial procurement or innovative procurement. And, provided the expenditure, I think it's less than 214K, we can use those mechanisms to, co-design. Very, very often, as I mentioned, we're using the quadruple helix in our living labs. Typically, we'll have the government body, which is us. We'll have academics. We'll have the SME involved. Sometimes there is a large company involved as well. And then we have patient groups. So one of our living labs is with Centric Health, which is a network of GP general practitioners in Ireland. But we also have Roche Diagnostics involved in that, and we have patient groups, and we're doing a living lab pilot around heart failure patients. And in this case, actually, the SME made a decision. They were actually going to fund their whole involvement, and that's turned out to be really successful. So in that case, there was no procurement, barrier. And we've now got to the stage where we have some really compelling results. We have a demonstrator of over 100 patients, and we know that there were 33 events that in the past would have led to hospitalizations, but now have resulted in 0 hospitalizations. And we're now at the stage, okay, we have to think about the business model on this, and we have one of our national health insurers working with us. So how could we reimburse this as a service? So in this case, we were essentially able to do it for free because we had shared resources. And now that we have proved the clinical value and the business case, we're now trying to work out what is the business model and who pays who and who actually captures the benefits. So I think there's a number of different mechanisms, but we always start small with a small proof of concept with maybe 20 patients or whatever, and then we try and scale it up to a demonstrator. And then ultimately, if the demonstrator is successful, we go to broad adoption, and it's at that point option that we have to go for a tender. When we try and keep the tenders as lightweight as possible.
So if I have to identify a learning here is if you cannot break the barriers, keep them low as much as possible. That's, I think, what you guys have done in a certain way, trying to limit the complication as much as possible, because a minimum complication is a required sacrifice. Going to the end of our conversation, Martin, if you have to share with your peers across the globe that are trying to do what you guys have done, the top 3 recommendations, top 3 tips, what you would suggest, what you would say?
That's a good question, Alberto. Well, I think you've got to enlist high-level support in the organization for a start. So you need some air cover. If you're going to be an innovator, you are actually going to you're going to need some wingman and somebody that will help you as you go on your innovation mission. So you certainly need high-level support. That's the first thing. Secondly, I think you need a good team around you. And very often what you find, and what I found in my previous roles, is that people who have sort of, a nous for innovation or an innovation instinct, they kind of self-select into your organization. So I've been lucky that I've had some really fabulous people see what the vision I had, and they have self-selected into the team. So you kind of, operate kind of like the Marines. You're the first people that sort of secure the territory. And, you have to, the motto of the Marines is Semper Fidelis, Semper Fi. So you have to really, build a loyalty in the team. But if you have a small team, that team can be a real catalyst. So we've talked about leadership. We've talked about, having a good small team. And then 2 other things. You need to identify, certainly in healthcare, you need to identify either the clinicians or the business leaders that are up for change and are willing to co-innovate and share the risk with you, because there is a shared reward, but there also is a shared risk. But if you have, for example, the national clinical lead for a particular area, for respiratory or for diabetes, working with you, well, people will sit up and take notice, and they will be less likely to take a shot at you. They still take shots, but they take less shots. And then the last thing is you have to have some successes. So you have to have quick wins, and those quick wins actually build confidence, and people say, oh gosh, these guys know what they're at. Maybe we shouldn't bet against them. So having those quick wins and telling the narrative, the story, the innovation success. So it's actually really helpful, Alberto, to have this conversation and have the recognition from Mind the Bridge and ICC. We're delighted with that. The external validation is very helpful, and it helps us tell the story internally so that we can actually move to more transformation and more success.
Thank you, Martin. And I think one of the most interesting things that, again, I was thinking while hear you talking and sharing your best practices actually are the same best practice that the top innovation organization, also the private sectors are adding. And so I think that at the end, that you're working in the public and the private sectors, what's really important is what you guys are doing. And again, top level buy-in, having a good team around you, and identify external partner that might give you extra reputation and get some quick wins, and properly communicate them, because communication helps. I think is probably a good starting package for organization who want to innovate, either public or private organization. But again, congratulations, because innovating into public administration is an extra burden. And so again, since you got the results, that makes you for getting extra congratulations. So thank you for sharing your experience. Keep up with the good work, and looking forward to stay in touch with you, Martin. Bye.
Great. Thanks very much, Alberto. Great questions.